بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا محمد معلمنا وقدوتنا وحبيبنا صلى الله عليه وسلم. اليوم سيتم استكمال موضوع الCRRT. هنبدأ اليوم موضوع SLED Low Efficient Daily Dialysis. SLED I think is most common in our country, more than CRRT. Just to review the previous order for CRRT, we mentioned just to remind you by the most important thing for the CRRT, if I found one patient with hyponatremia. I just searched for this paper and I asked my colleague here for CRRT with hyponatremia. Just don't remind this. We can use this hypotonic fluid to avoid overcorrection. We can use this equation for how much amount D5 water rate infusion during a CRRT to keep, because you know our dialysate, as mentioned in the last presentation, is around 140. Our dialysate sodium is 140. Just will divide our target, our baseline sodium 140 minus target our sodium. What you need our sodium to be reach your target, how much? If I have one patient is sodium 110 and my target to increase only 6 millimeters, my target 116, 140 minus 116 divided by 140 multiplied by desired clearance, amount of dialysate and replacement. Okay, desired clearance, amount of dialysate and replacement. If it's 2.5 liters, this example, for example, our order, this mode of our dialysis. Whatever the mode you chose, I told you before in the previous presentations, the best mode is CVV HDF. And if you have one patient with sodium 110, we can just keep this slide in your mind for any patient with hyponatremia, how to calculate or how to protect your patient from overcorrection by keeping this slide with you. At least this is number one, and I will give you a second choice. I already put in the first comment in my video on YouTube. This equation I will discuss in the next slide after this. For example, this patient 110 and my target already 120 or 116, whatever your target, and just you will calculate how much you will give as a replacement to your D5 water as 357 by this equation. You should give both the filter when the blood will enter to the patient after the filter. This just for patient with hyponatremia on CRRT. This is one solution. The second one I sent it already in the first comment. اول تعليق هتلاقيه في الفيديو بتاعنا على اليوتيوب، هتلاقي اول كومنت هتفتح unitedkidney.com، هتفتح البتاع ده وتعمل اي agree, and after that you agree for that, and after that he will open for you this calculation. As we know, our dialysate sodium concentration 140, just this fixed already. Volume of your dialysate, dose of your dialysate, as we mentioned before, dose 25 multiplied by 70, around 1,800. And your desired sodium, if my patient's sodium is 110, sodium now will be 116. And then serum sodium concentration of diluting fluid. Diluting fluid either use half normal saline or D5 water. If I will use D5 water, means zero sodium. If half normal saline, 7.7. After that, you will both calculate. He will give you amount of replacement you will give to the patient as a replacement D5 water. Okay, I am using here D5 water because this is zero sodium. If I choose half normal saline, each liter 77, by the same equation, 140 is the dialysate sodium, and this is the volume of dialysate, and our desired sodium from 110 to 116, and your sodium 77, I will use half normal saline. This calculation will give you 1,100 as a replacement. This as a replacement you will give as a to protect your patient from overcorrection with hyponatremia. أتمنى الرسالة تكون وصلت ووضحت عشان الCRRT يكون اتقفل بكل مشاكله. الهايبرناتريميا، تعالى بقى الهايبرناتريميا. طبعا جه العيان الصوديوم بتاعه 170 وعايز يغسل في العنايه وحالته متنيله والعيان مركون ومعمول ونجلكتد برضه، لو حسب على حسب اللي في العنايه، فالمهم ممكن تلاقي الصوديوم بتاعه 170 وازاي هتحط على CRRT والدياليزيت في CRRT 140. يعني انت لو سبت العيان ممكن يحصل له اوفر كوركشن 30 بوينت، ممكن خلال اقل من 24 ساعه ممكن العيان يخش في سيربرال ايديما ويحصل له مشاكل. وممكن ينتهي بالديس طبعا، العيان ممكن يموت منك في الحاله دي. فالمهم اوعى تنسى المعادله ديت، او تقرا الصفحه دي في الهايبر اناتريميا وكان يوز هايبرتونيك سالاين انفيوجن. طب فين المعادله اللي هنحسب بيها ازاي نعمل كوركشن او ريبليسمنت؟ المعادله بتاعتك هنا هي 3% انفيوجن ريت. هتدي انفيوجن ريت بعد الفلتر، بعد العيان ما يكون داخل العيان از ريبليسمنت، وتحسب التارجت صوديوم بتاعك. انت عايز الصوديوم بتاعك كام؟ هو مثلا 170، انا عايزه 160، هنكتب 160 ناقص 140 على 513 اللي هي كل لتر من هايبرتونيك سالاين ماينس 140 في الديزايرد كليرنس اللي هو مثلا الدياليزيتور ريبليسمنت حوالي 2.5 لتر. تمام. هيديك نسبه كده ان انت تمشي بها في الساعه، يعني هتديك the rate of hypertonic infusion هتبقى مثلا 0.13 لتر بر اورز، يعني ممكن 130 مللي في الساعه، 100 مللي في الساعه، 50 مللي في الساعه، على حسب ما هيطلع لك بالظبط هتحسبهم بالملي في الساعه. تمام. ديت المعادله اللي هتحسب بيها ازاي ما تحصلش اوفر كوركشن للعيان هايبرناتريميا 2. كده انت قفلت معظم كده المعادله معاك، تحسب بيها براحتك كده لغايه ما توصل للريت اللي انت هتوصل بيه، بحيث تخلي العين بتاعك سيف مع الدياليسيس سواء هايبوناتريميا او هايبرناتريميا. اتمنى الرساله دي تكون وصلت. تمام. النهارده هنتكلم عن السليد slow low efficient daily dialysis because it's the most common in our country. الغسيل عن طريق مكنه الغسيل العاديه جدا by the conventional hemodialysis machine. I can use the SLED, but the difference between the conventional regular hemodialysis and this SLED, just only time. The time and the blood flow and dialysate flow, everything will be, time will be prolonged, maybe at least 6 hours, sometimes 8 hours. We are using 12 hours, and we are using here most of our patient 24 hours SLED. And the blood flow, the blood pump maybe 200, 250 maximum, and the dialysate flow just only 300 or 250 also. Many terms for this slow efficient dialysis: sustained low efficient daily dialysis, or extended daily dialysis, or prolonged intermittent renal replacement therapy, go slow dialysis. Whatever these all mnemonic names for this SLED. This fundamental principle of SLED, the application of conventional hemodialysis technology over a more prolonged period, as I mentioned before. نفس الغسيل العادي، بس أنا هنا بستخدم فترة طويلة، وقت بياخد معايا وقت طويل من 8 ل 12 ل 24 ساعة. to provide therapy with hemodynamic، يعني على اساس تتعامل مع الهيموديناميك بتاعت العيان، لان معظم العيانين دول طبعا بيبقوا هيموديناميك ستيبل، فانا بحاول استخدم السليد على اساس ان ما يحصلوش دروب في البلاد بريشر ويقدر يتحمل الغسيل لو انا ما عنديش فاسيلتي للسي ار ار تي. This as regard the rationale for SLED is adequate, efficient, and safe renal replacement therapy to hemodynamic and stable patient in ICU. If you don't have facility for CRRT machine, okay, you can use this no other way and just increase your time and decrease your blood flow and dialysate flow. But doesn't CRRT already address this? What means is not typical like CRRT, but if you don't have, just use. SLED is a direct response to shortcoming of CRRT. No mortality benefit over conventional dialysis. Need for anticoagulation, sure, because if you not give anticoagulation in the SLED will be ended by coagulation problem and many alarms and circuit loss, and will change many circuit for your patient. And the complex protocol you will see now, and the high cost because you need nurse 24 hours and the machine working 24 hours, more dialysate and other. All I think all is costly already. SLED prescription, duration, just to know how you can prescribe our SLED. At least you can start by 8 hours at the first, and after that you can decide if you can extend it to 12 hours or 24 hours according to hemodynamic stability and the clearance and everything your patient can tolerate, and the fluid removal also, because most of our patients will need fluid removal. According to the hemodynamic, you can decide to extend or decrease. Crucial طبعا for maintenance low alta filtration rate. يعني please don't rush by alta filtration. If I do 8 hours, just try to take 1 liter, 1.5 liter, 2 liter maximum. Don't increase more than this. Achievement of prescribed duration may be sensitive to nursing personal pressure. Yeah, the problem for most of our units here, this little order done by our hemodialysis nurse. You already did more pressure in our hemodialysis because short staff everywhere in the world, and the nurse will be staying only beside the machine, maybe 12 hours or 24 hours. You will do more burden on our nurse staff. SLED prescription, any conventional dialysis machine acceptable ideally the one used for chronic patient at your center. Any dialysis machine can do SLED order. Problem in nursing staff, you can solve this problem by train all ICU staff or some of our ICU staff to continue dialysis. Just the hemodialysis nurse can establish or set up your machine, hemodialysis machine, and the ICU nurse can continue and treatment as a part of her treatment and management of her ICU patient, and suggesting use standard high flux dialyzer in use for maintenance dialysis. Blood flow, just at least you can start 150, 180, 200, 250 as your patient will tolerate. Okay, this is regarding blood flow. Dialysate flow, as you can increase if more frequent clotting, just increase your blood flow, and please we need good catheter function during the SLED. And dialysate flow, please just you can start 100, 150, 200, don't increase, and the maximum 350. From 100 to 350 you can start according to hemodynamic of your patient, but better to start by 300 ml per minute. Regarding your sodium, we have, you should, as we mentioned before, in the CRRT, hyponatremia like that, please check your sodium and see where you are. If your patient, or we can start from sodium 140, 145, 150 at least, to keep your patient with high osmolarity and keep your patient hemodynamic stable during the dialysis. We want to trend your sodium as according to your sodium. If the patient hyponatremia will give lowest sodium. If the patient hypernatremia will put highest sodium. If the patient hemodynamic and unstable, better to put highest sodium also. And will and by the same calculation, we have different calculation to give. During dialysis, we can give, if I have patient severe hyponatremia, I can give 500 empirical every hour, as our experience here with our patient. Every hour during the dialysis, if I dialyze my patient 4 hours or 6 hours, just give 500 to replacement fluid, D5 water, to the patient each hour during the dialysis, and check your sodium every 2 hours during the dialysis, to decide to increase to 700 or 1 liter each hour according to frequent lab monitoring. As regards the potassium, because we have longer period dialysis, at least 6 hours, 8 hours, 12 hours, just if the potassium 3, if the potassium less than 4.5, you can use K3 pass. If the potassium less than 4.5 millimole per liter, if the potassium more than, I think this, if less than 4.5, and you can use 4 if the potassium less than 4.5, okay? If less than 4.5, I will use 4. If my potassium is more than 4.5, I will use K-pass 3. This is a K-pass, this is a dialysate potassium 3 or 4. 3 if the potassium less than 4, and 4 if the potassium more than 4.5, okay? So I think is clear also. 3 with a low potassium, less than 4, and 4 with a high potassium, with a low potassium. 3 with a high potassium more than 4.5, and 4 with a low potassium less than 4.5. It's confusing. And the calcium, according to your calcium of your patient, I have patient post parathyroidectomy, I will use this 1.75. I have patient with hypercalcemia, I will use 1.25. Okay, according to your patient malignancy metastasis with hypercalcemia, I will use this 1.25. As regards the bicarbonate, according to acidosis, 30 to 35, I think you can use 40, even 40. If your patient with severe metabolic acidosis, I can increase the bicarbonate to 42. Okay, 40 بالمثل, either 30 or 35 or 40. Be prepared to add phosphate fleet enema phosphate component. To dialysate fleet enema, you can use 130 or 120. 120 can increase your phosphate, 120 equal to 1 millimole phosphate, especially if your phosphorus less than 1. Okay, don't forget this in your CRRT, because prolonged dialysis and this patient AKI already in ICU, not CKD patient, maybe will go to hypophosphatemia, and this will impair your mechanical ventilation and respiratory muscle, and will affect your patient and the ventilation already and the muscle weakness. Please don't forget phosphate fleet enema to your dialysate of phosphorus less than 1. Often no anticoagulation is needed. Some patients post-surgery and complicated and bleeding or post-trauma, maybe you will use heparin-free or low-dose heparin, tight heparin, like what I mean, 500 bolus and then 500 each hours. All molecular weight heparin, we don't have experience with it till now. When the bleeding is low risk, okay, you can use tight heparin. Heparinization of the circuit, just do heparinization by 1000 unit ml. 1 liter normal saline, and you can use regular heparin if no contraindication. My patient DVT, my patient pulmonary embolism, my patient with metallic valve, just use regular heparin 1000 unit bolus, then 1000 each hour, or tight heparin 500 unit bolus, then 500 per hour. For no heparin, we can use 200 ml normal saline maybe every 30 minutes or 1 hour as flushing if no heparin. And 200 ml normal saline if systemic blood pressure dropping less than 90, just to give as an order for your nurse to keep your blood pressure stable during dialysis, and also increase the levofed and the vasopressin and the other inotropic support for your patient. Ultrafiltration carefully tailored as to patient clinical states and perceived volume overload. To approach, go slow initially, titrate based on hemodynamics. Please go slow for ultrafiltration for your patient. Consider ultrafiltration profiling too. You will increase your ultrafiltration in the first hour, and after that you can decrease to keep osmotic gradient inside your blood vessels to keep your patient hemodynamic. And daily SLED or at least isolated UF on non-dialysis days is an important consideration. If your patient no need for daily SLED and the main issue for dialysis just to remove fluid, we can do isolated IGF every other day, 1 day dialysis with ultrafiltration and 1 day ultrafiltration isolated UF only. Intermittent hemodialysis, as I mentioned before, this patient SLED maybe time, I think from 6 hours. And we have some problem already. We have this new patient who can start just only first day 4 hours, and then second day 6 hours, then third day, or like this to avoid disequilibrium syndrome. And we can use large or high flux, and also blood dialysate flow around 300 maximum, and 300 ml per minute. I will give you 30 liter per hour. And this patient also blood flow, I think 200 is okay to start. I think 400 is difficult if the patient hemodynamic and stable. And the dialysate composition, as we mentioned, sodium, potassium, bicarb, and calcium. I think this is order for regular patient more than the SLED order. And just consider using the appropriate prescription for your patient, and the safety checklist in your patient with AKI in ICU. Please review your patient and the hemodynamic and the dose achievement, and our aim to achieve euvolemia, and review your lab and adjust your prescription according to lab as regards electrolytes and others. And the access optimization, we need good access to keep your SLED order running, and the recovery, just observe daily. Our job to observe urine output and the labs creatinine, especially creatinine for renal recovery. And the medication, just check if your patient on antibiotic, you need antibiotic adjustment, and avoiding nephrotoxic medication is prescribed while ICU, and avoiding IV contrast during this. I think SLED order is clear now. Just as for summary, we have to prescribe at times. At times maybe 6 hours at least to start, and then increase 8 hours, 12 hours according to your facility. And just to keep blood flow, just to start by maybe 180, 200, like new start hemodialysis patient. And the blood dialysate flow maximum 300. And the other parameter, as I mentioned before, is for SLED, because SLED are common in our country. You can collect all the previous data, and you can put your protocol in your ICU to be standard protocol for any new colleagues came to ICU. You should fix this standard order for SLED in every ICU you are work. This should be done by nephrologists and followed by nephrologists and ordered by nephrologists. As regards the IHD, because some colleagues asked, how can I prescribe IHD order, regular hemodialysis order? If we have patient already, we'll start hemodialysis for him. This patient 6-7 years old man with polycystic kidney disease, hypertension, dyslipidemia, and you plan to start his for him dialysis, whatever the indication. Is uremic symptoms of volume overload, hyperkalemia, acidosis. Is already have right CVC, central venous catheter, due to an immature left brachiocavalic AV fistula. Is in the serious disease, is a past medical history. AV fistula occurred 3 months ago with right tunnel CVC in situ, and this is his medication: ramipril, amlodipine, simvastatin, calcium carbonate, Prex. Is taken weekly, and after that will divide this on dialysis better. Examination: his heart rate is okay, blood pressure is okay, the 160 is 90, is good for dialysis. Blood, his weight 71, GVB 4 centimeter, there is peripheral edema, little bit volume overload, chest is clear, heart normal, lab, potassium 4.8, bicarb 20, and hemoglobin 100, calcium 2.2, other electrolyte is okay, phosphorus little bit elevated, 1.9, BTH is high, normal 7, up to 7. Writing hemodialysis order. How can I write hemodialysis order? Just for hemodialysis, the first standard items: time. How much your time? For any new start hemodialysis, put this in your mind. Not every patient 4 hours. This is a standard for chronic patient. But if patient already new start hemodialysis, first session should be 2 hours. Second session 2.5 hours. Third session 3 hours. Then 4 hours. Each session 3 times per week, to minimize dialysis disequilibrium syndrome. Okay, not to take more urea from your blood, and this will lead to cerebral edema and the seizure and the coma. And during the first dialysis, if you extend your dialysis more than 2 hours in the first hour, especially patient with high urea or new start hemodialysis. Okay. Now, clear again. Time is the most important. If you have new patient start dialysis, please. Just first session only 2 hours, second 2.5 hours, third session 3 hours, and then we'll continue 4 hours according to your assessment. Then fix your patient 3 times per week. Blood flow will start first session by 180, 200, 250 maximum. Better to continue to start by 200. And if the patient with high uremic and you are afraid from dialysis, disequilibrium syndrome, please start 180 ml per minute. For new started dialysis, then maximize as the patient tolerated 350, 400 after its third session. Dialysate flow, I will start by 300 for new started dialysis to avoid removal of more urea. Then increase 500, 700 according to your center protocol. 500, 700 ml per minute. This QD dialysate flow 500, 700 ml per minute. New start is 300 ml per minute. And this blood flow 180, 200, 250 ml per minute for new start. Then start this increase, then increase to 200, to then increase to 350 to 400 ml per minute. Sodium. We can start with the lowest sodium. If the patient hyponatremia is the lowest one, I think 130 on the machine, and the highest one 150. Because if the patient hypernatremia, please don't forget this. And the potassium, we can use K1 if my patient is chronic hyperkalemia, 7, 8. I can give him 2 hours. First 2 hours K1, and the second 2 hours K2. If your patient hypokalemia, we can use 3 or 4, if less than 4. Bicarb, you can use 30, 35, 40 according to metabolic acidosis of your patient, but the standard is 35. The standard here 138 in the sodium, the standard here 2 in the potassium, or 3 according to your potassium. If less than 4.5, you can use 3. If more than 4.5, you can use 2. Bicarb, the standard here is 35 or 40 if severe metabolic acidosis. Calcium 1.25 if your patient hypercalcemia. If your patient hypocalcemia, you can use 1.75, the standard 1.5. Fleet enema, don't forget this sodium phosphate enema, fleet enema 120 ml on dialysate. If phosphorus less than 120 ml fleet, final phosphate concentration will give you 1 millimole per liter, okay? Temperature standard 36.5 or give or better 0.5 below your patient body temperature. حط له درجة حرارة 0.5 أقل من درجة حرارة المريض during the dialysis. Ultrafiltration as target weight if new, as a target, most of our chronic hemodialization have target weight already. His weight already target 70. What means by target weight? This weight after dialysis, no hypotension and no symptoms of hypotension or volume depletion or cramp. And the patient is stable after dialysis on that weight. No volume overload, no volume depletion after dialysis. This means the target you reaches the target weight for this patient. Blood pressure is stable also. If new start dialysis, you will daily assess your patient and you'll put empirical ultrafiltration and you'll assess his blood pressure after and post, the weight after and the post, clinically if the patient symptomatic or not, until you reach target weight. And you can also assess by chest X-ray if you have facility, till fixes the patient target weight. This target weight start to be hypotensive after that, after this weight or hypotension start to be occurs or cramp, or patient unstable after after dialysis. It means you are near the target weight. You can adjust and delay 0.5 up or down until you fix, until your patient will be stable after dialysis, and you can at that time fix his target weight and will be monthly assessed after that. Anticoagulation, no heparin if new hemodialysis patient. Don't give heparin. Don't forget this point, please. No heparin if new start hemodialysis or bleeding or pericardial effusion. It will be transferred to hemorrhagic effusion if you will give heparin. Please put this in your mind. Untitled heparin 500 polas in 500 every hours, or regular heparin 1,000 polas in 1,000 every hours during the hemodialysis. And please, with your patient with AV fistula or AV graft, please discontinue heparin 30 to 60 minutes prior end of your hemodialysis, because it will take long time to nurse to press in a AV fistula and to stop the bleeding. To writing hemodialysis order, don't forget filter. We have different type of filter according to your center and the time. 4 hours, 3 hours, 6 hours as your facility, and anticoagulant, what type of anticoagulant we use, and the blood flow, dialysate flow, and dialysate temperature, ultrafiltration, your target weight, dialysate electrolyte, sodium, potassium, bicarb, should mention all this, and the calcium, and phosphorus if you will add fleetinema, if your patient hypophosphatemia, and whatever the medication your patient receive, iron or Aprex or antibiotics, you should order all this in your hemodialysis order. We have here, 2 4, as mentioned before, 2 to 4 hours, large flux, and this is dialysate flow, blood flow, and this composition of sodium, potassium, bicarb, calcium. Ultrafiltration, what is your target, 2 liters, 3 liters, 4 liters, or according to target weight, anticoagulation, heparin or no heparin. This again, hemodialysis according to type of your filter and available in your, we have here FX 800 or 1000 or FX 120 or filter for any patient with allergy to the previous one. Filter for patient with allergy, time for our standard blood flow 350 to 400 as the patient tolerated, and no hypotension or chest pain during that. And the dialysate flow 500 ml per minute, or 700 or 800, you can increase according to your clearance or KT over V or the patient's general condition or his lab urea and the creat. And sodium 138 the standard, and you can increase or decrease according to your serum sodium, potassium K3, K2. You can use according to your patient's sodium, and you can use K1 if your patient chronic hyperkalemia 7 or 8 and recurrent physician will emerge. Better to put him as you can in K1 at least for 2 or 3 hours, and keep the last 1 hour or 2 hours K2 to avoid any cardiac arrhythmia after from hypokalemia. Standard calcium 1.25 or 1.5 or 1.75 according to your calcium, bicarb 35 or 40 according to your serum bicarb. Target weight, if you have target weight, you will put. If you don't have, you should assess according to the blood pressure and the volume status. You can assess how much nurse or hemodialysis nurse who can remove during the dialysis. And you can use regular heparin or no heparin or tight heparin, and please just stop 30 minutes before the end of your dialysis. Dialysate temperature 36.5 or 36 or 0.5 less than your body, your patient body temperature, and you can add a Aprex or iron or antibiotic each hemodialysis IV. And this just to review our dialysis order. Again, schedule of your patient. We have here Monday, Wednesday, Friday, TTS, and our country is a different schedule, I know. A temperature as in this review, dialyzer, what type of your dialyzer, ultrafiltration, how much you remove, blood flow, sodium, potassium, just to summarize all we said. And وربنا إن شاء الله يزيدنا ويزيدكم علما بإذن الله. ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم. ونلقاكم قريبا من موضوع مهم من موضوعات النفرولوجي. كما وعدتكم هنبدأ بالموضوعات المهمة والموضوعات المعقدة في النفرولوجي والموضوعات الإمرجنس واللي احنا كلنا محتاجين نفهموها، وهنحاول نوصلها لكم بطريقة مبسطة وبطريقة كلينيكية وليست طريقة كتب ولا دش ولا الكلام ده كله. أنا بديك الحاجة اللي ما حدش فعلا بيوصلها لنا أو ما حدش كان وصلها لنا أصلا. ازاي تكتب وازاي تتعامل مع المريض، ازاي بقى تدي المريض. انا فاهمين نظري وبنسمعه نظري وبنجري وبنعمل ونخلي الكتب والكلام ده كله، لكن دايما المحصله بتاعتنا كانت زيرو. تيجي قدام المريض تكتب ازاي هيموداليز اوردر، مش عارف. طب نعمل ازاي سي ار ار تي اوردر، برضه مش فاكر او ما اعرفش اكتب ازاي سي ار ار تي اوردر، ما اعرفش ازاي اعمل سليد اوردر، ما اعرفش ازاي اكتب هيموداليسيس اوردر، ما اعرفش ازاي اتعامل مع هايبوناتريميا. كل الكلام ده انا اديتك اللي بيتعمل، البروتوكولات بقى اللي بتتعمل، مش جايد لاينز ولا كتب ولا تكست بوك ولا الكلام ده. انا عايز ازاي ادي المريض، ازاي اخدم المريض حالا، وازاي انفع المريض. ان شاء الله احاول اوصل لكم كل الحاجات ديت وكل الحاجات المهمه اللي انت محتاجها في حياتك وفي شغلك في النفرولوجي باذن الله. وانا اسالكم الدعاء بالتوفيق، واحاولوا توصلوا كل المعلومه لكل زمايلنا الجدد في قسم الكلى او لاي حد شغال في النفرولوجي. وانا اسالكم الدعاء بالتوفيق، ولا تنسوا دائما الصلاه والسلام على حبيبنا محمد صلى الله عليه وسلم. ونلقاكم قريبا باذن الله في فيديو قريب جدا باذن الله. والسلام عليكم ورحمه الله وبركاته.